Welcome to the JOWMA podcast, presented by the Jewish Orthodox Women's Medical Association. Every week, hear from expert medical professionals as they share up-to-date insights on health topics to help you live your best life physically, mentally, and emotionally. Join us as we navigate the ever-changing landscape of healthcare and strive to improve the health of the Orthodox Jewish community.
Hi, I'm Rena Goldberg. I'm a second-year medical student in Hackensack Meridian School of Medicine, and I'm here with the JOWMA Specialty Spotlight podcast. The Specialty Spotlight podcasts are geared towards pre-med and medical students interested in learning about different medical specialties. Today, I'll be talking to Dr. Beth Popp. Dr. Beth Popp is a professor on the faculty of the Incan School of Medicine at Mount Sinai in New York, specializing in hospice and palliative care. She completed medical school residency and fellowship training in medical oncology at Indiana University of Medicine, followed by a clinical research fellowship in cancer pain management and palliative medicine at Memorial Sloan Kettering Cancer Center. She has started and led palliative care programs at 3 New York City teaching hospitals. She has served on hospital ethics committees for most of her career, and on the policy committees of state and U.S. national palliative medicine professional societies. She presents regularly to community groups to clarify the role of hospice and palliative care in healthcare systems. She has also been involved in educating rabbinic leaders about the medical aspects of serious illness and end-of-life care. Her clinical interests include early palliative care for cancer patients, providing palliative care in the outpatient setting, communication skills for those in serious illnesses, and the unique palliative care needs of patients from religious and cultural minorities in the U.S., including but not limited to Orthodox Jewish community. She has lived in New York since 1993, where she lives with her husband and is the mother of 4 sons. Thank you so much for joining me today, Dr. Popp. I'm really excited to interview you for this episode. You really have such a fascinating specialty, and I'm looking forward to talking to you about it. I'm going to start with a more general question before we get into your specialty of what made you choose a career in medicine, and what characteristics would you think makes one a good fit for medicine?
Well, first, let me just say thank you, Rena, for inviting me to do this. My specialty is sort of small and young one, and often isn't the first thing that comes to mind when people are thinking about careers in medicine. So I really appreciate your thoughtfulness in including me and giving me this opportunity today. How did I wind up going into medicine? That's a good question. I grew up in the 60s, and it was a time when roles for women were really changing a lot in general in society. And I did well in school, and I liked science, and I wasn't going to become a science teacher or a nurse. And everybody said you should go to medical school, because those were kind of the things you could do if you were a woman and you were good at science. And going to medical school was sort of a new option for women. There weren't a lot of women in medicine. Just to give you a sense of how much it's changed, your medical school class, I would imagine, is about 50% women.
More than 50%, actually.
My medical school class was less than 25% women.
Oh my God.
Yeah. And I don't think I had more than 5 attendings who were women. And none of them, maybe one of them was a full professor. So It was really, it wasn't like I was a complete trailblazer. It wasn't the first one by any stretch of the imagination. There were plenty of women who came before me, but we were still really a minority within who was going into medicine. And I think it was still less common for Jewish women to go into medicine. I don't know that there were very many other Jewish women in my medical school class, and that's Jewish in general. I did not grow up from, and I wasn't from when I started medical school. And then when you think about sort of our group in terms of JOWMA and the premed students who are thinking about going into medicine now, it's really a very different time, both in terms of having peers who are thinking about going into medicine and having a support group and mentors who have been down that road.
What characteristics do you think make someone a good fit?
I think it's a a few things. One is you have to like people, because with very few exceptions, in medicine, we deal with people. We deal with people at a time that's often very pivotal in their lives. In many areas of medicine, it's a crisis, and a scary time. Sometimes it's, we think about like colleagues who deliver babies. It can be a very exciting, positive time, but giving birth is a really pivotal time in one's life. So whether it's pivotal in a positive way or pivotal in a more difficult way, you're encountering people at times of enormous change, and change is always stressful. And you have to like people to enjoy being with people when they're going through something that's stressful. One needs to be able to master the material. So you have to have an ability to do well in the classroom setting, and be a very motivated learner, because, there are so many things that are going on in medicine now that nobody even imagined when I graduated from medical school 35 years ago. And you can't just keep doing what you were doing when you graduate from medical school. You have to learn to do all of the new things and use all of the new techniques or medications that are developed. And, progress continues to be made after you finish school and training. You have to like to solve problems, because much of medical diagnosis is solving a problem. And you have to enjoy that process. You have to have a lot of curiosity in approaching situations. And liking science is probably helpful, just because there's a lot of sciences that you have to do to get there. And it's easier to do those things if you like them. There's not as much hard science once you get through your first year of medical school, unless you choose to be a researcher in the basic science world within medicine. And so those are the things I think that really help one see whether they might be suited to go into medicine.
I was actually just talking to a facilitator yesterday who was saying that what you were saying about how there's new information every second in medicine. So it's more about learning how to think and how to approach an issue than having all the information down pat, especially with how much information we can access every second nowadays. Just to go into your specialty, which is palliative care, which is really fascinating. Can you tell us a little bit why you decided to go into your specialty?
And well, it wasn't something I thought about or knew about, and it really sort of barely existed when I went to medical school. I went to medical school thinking I wanted to be an orthopedic surgeon.
Very different.
Very, very different. And very quickly realized that probably wasn't a good fit for me, but I knew something about orthopedics from having been an orthopedic patient. And so that was what I knew of medicine, together with general pediatrics. And orthopedics seemed a little bit more interesting to me. And when I figured out that I didn't want to be an orthopedic surgeon, I kind of had to start thinking about what I did want to do. And I wound up falling into a job the summer between my first and second years of medical school, which was the one summer we had off. And I worked in the lab of a junior faculty member who was an oncologist. And I wasn't really a basic science person, and that made me not so excited about the job, but there weren't other jobs available, and he really needed somebody in the lab. So he said, you know what, I'll take you to the office with me one day a week when I have clinic, and you'll get to see what things are like that are a little bit more clinical. And I remember I came home and said, like, cancer is so depressing. I would never want to be an oncologist, but at least I'll know I can rule a specialty out if I go and do this with him. And he turned out to be one of probably 3 mentors that I've had in my career who were really influential, because there were situations we saw that were sad, but I also saw the intense relationships that he got to have with his patients, and the way he accompanied his patients through very challenging moments in their lives, in a way that helped them feel supported and knowing that people were doing their best to take care of them, and using all the tools available in the ways that made sense. And so I decided I would go into oncology. And as I was finishing, you have to do internal medicine first. So as I was finishing my internal medicine residency and getting ready to start my oncology fellowship, I had started getting interested in sort of how can we help make it easier for patients to live with cancer? Because I thought someday somebody really smart will figure out the cure. But until then, people are trying to live with their cancer as well and as long as they can. And many of the treatments we have now were not available then. So as well as long as they can was sometimes a few years, sometimes a much shorter period of time. But it was a time that was really, people were very strongly affected by symptoms, either related to the treatment or the cancer itself. And so I got interested in managing those symptoms. And that's what eventually moved me towards palliative care, long story short. It was a place where people who had serious illnesses and had a very high symptom burden were getting those symptoms addressed. And the field was in its real infancy when I was finishing my oncology training. Now, there were 4 places in North America, 2 in the US and 2 in Canada, where somebody could get training. It wasn't recognized as a specialty. There were no formally accredited training programs. Everything was sort of informally grant funded. And that meant there was a lot of flexibility, but it also meant there wasn't a lot of roadmap.
Well, can you tell me a little bit more about your path towards palliative care? It sounds like it was more of a one that you had to pay for yourself because there wasn't a lot of institutions already built up.
The path is really different now. My path really came by way of oncology. And many of the people who were early leaders in palliative care came through oncology from having an interest in managing symptoms in patients who had serious illnesses and really helping them navigate the journey of having a serious illness, especially when we did not have ways to make that serious illness go away and stay away forever. We might be able to make it go away for a little while before it would come back. We might sometimes had ways to slow it down. And there were people who had early diseases that were cured, but sometimes they were left with side effects from their treatment. So where I trained in the Midwest at Indiana University was a major international center for testicular cancer because some of the treatments were developed by academic oncologists there. And that was a disease which affected young men in the prime of their life, but even when it had spread significantly, was still curable. And that's a very unusual thing for a cancer. And so we had these young men who were able to be cured, but they had side effects like numbness and tingling in their fingertips as a side effect of one of the treatment. Or while they were going through treatment, they had terrible pain, or it affected their lung function and they wound up being short of breath or, months or years or potentially the rest of their life. Not to the point where they couldn't function, but where they were functioning in a different level than they were before. They really had to adapt. And so I became very interested in how we manage those symptoms and how we can help people adjust to the new normal in their life when they're successfully treated and adapt to the process of a progressive illness and prepare themselves and their families if we're not able to have a good outcome and they're going to eventually die from their disease. So we were doing, there was research happening there on anti-nausea and vomiting medicines for chemotherapy-induced nausea. A lot of issues with pain come up in cancer patients. So there was a lot of interest in developing effective ways to treat pain and other kinds of side effects like neuropathy, this numbness in the fingertips. If you're a 30-year-old man and you get cured of your cancer, but you can't get dressed because you can't do shirt buttons or you can't do a zipper and fly on your pants, it really impairs your ability to function in the world the way any other 30-year-old man would. And so those were things that really piqued my interest. And I started looking around for people who were doing research in these areas. And like I said, there were 4 centers, 2 in Canada and 2 in the US. And I wrote them letters. I think I sent them faxes rather than actual US mail, but we weren't
Wow.
doing so much in email in those days, and said, I'm a, soon to be oncologist and I'm interested in these things. And I see that your group has written a lot of papers on it. Is there a chance I could come for a few months as a visiting fellow and learn some of the skills I need to do clinical research in this area? And they all said yes.
Wow.
And it was a very small field, and people were very eager to have others who wanted to go into it. And I chose to come to New York City, to Sloan Kettering, in part because I knew, even from the Midwest, that it was a really famous place. But it was the most interesting of the 4 cities I could have gone to. And I had a sister who had just moved to New York for a job. And so I figured it would give us a couple months while I was doing this visiting fellow gig to be together with her and see what it was like to live in a big city. And I wound up really falling in love with the field and deciding it was really what I wanted to do. And I wound up coming back to do a full fellowship, which was 2 years, a clinical year and a research year, and then worked in the field doing a combination early on of traditional oncology and palliative care. But there's lots of oncologists out there, and palliative care was, like I said, a kind of fledgling specialty. So there weren't a lot of us. And if there were 10 oncologists and 1 palliative care oncologist in a hospital, you really needed me to do the palliative care stuff more than the oncology. So as programs built up in places where I would find myself doing more palliative care and less traditional oncology. Now that it's a recognized specialty and there are accredited training programs, people who are interested and have trained, I believe there are 7 different specialties who co-sponsor fellowship training in palliative medicine. And the official name of the specialty is actually hospice and palliative medicine. And it's a 1-year fellowship. Many of the people who go into it train in internal medicine or family medicine, but we have had fellows who trained in psychiatry. We have some of them have stayed on where I work now, even as attendings. We've had anesthesiologists who have gone into palliative medicine, had a number of surgeons, and people from a number of different internal medicine subspecialties like critical care or pulmonary. I know someone who's a palliative care cardiologist. We've had folks who trained in emergency medicine and then did a palliative care fellowship here. So it's a specialty that really can incorporate a lot of sort of basic first levels of training and bring a lot to those different areas within medicine.
Wow. It sounds so interesting. And
it's, it is not something that is routinely encountered in medical school. And depending on where somebody does their residency and in which of these areas they do their residency, they may or may not have much contact with palliative care as they go through their training. As the specialties grown and become more integrated in both medical education and in health systems, that's changing, but it's still not often, it's still often the case that people don't have a lot of experience with palliative medicine early on in their medical training.
I find it so incredible, by the way, just going back to the beginning of your story, that you really put yourself out there and sent the letter to the 4 institutions that did palliative care.
I'm not sure if it was something I don't think I was explicitly told by my parents, but it's certainly something that I sort of grew up with and have incorporated. And my children got tired of hearing it as they were growing up. No one can say yes if you don't ask.
It's true.
And if you ask and they say no, you're in the same boat you were in if you didn't ask. So you really don't lose anything. I mean, obviously you have to do it in a respectful way and in a way that's appropriate, but people can't say yes and give you opportunities if you don't ask.
And it changed the trajectory of your career. So
it changed, not only the trajectory of my career, but when I came back and did that fellowship for the 2 years in New York, it's when I met my husband and wound up staying in New York. And so it didn't just change my career, it changed my life.
Something that I was thinking when I was reading your bio and everything, how do you have the heart for regular palliative care? Like, that seems like a very difficult and emotionally draining work to be in every day.
Yeah, it's something I thought about a lot early on. And I think everyone who's in the field figures it out somehow or another. For me, the fact that, being from and spirituality, as they would say in the lay world, is an important part of who I am. I'm not the one who decided that this person should get sick, and
Right.
it's not in my control whether they get better or not. And that's very clear in my head. What I can do, and I often have the privilege to do, is make sure that however that plays out, and often it does play out with someone dying, that I make it the least difficult it needs to be. And that if my involvement in a patient and family's hospital care during a critical illness and during the process of them dying makes it less difficult for them, then I've done something that's important, and I can be at peace with the other parts of it. I mean, there are times when it can be really sad. And one of the things I really like about the position and the department that I'm in now is that the need to debrief in some of the really very emotionally fraught situations or situations that hit very close to home to somebody on the team for one reason or another is recognized and acknowledged, and that taking time to debrief so that we can go in to the next day's work, to the next patient we need to see in a full way is recognized as something that's time well spent. It's not like we're coddling each other or we're wasting time. That's an important part of the process and making sure that we can continue to do the work.
See that. I mean, when I've been interviewing people, I guess I've been hearing a lot about these debriefing sessions for doctors during times of tragedy or hard situations. Is that a more recent thing, or have they been doing that in medicine for a while?
I think it's become more entrenched in more specialties, and there's been more recognition of times when it's needed, when there's obstetric calamity, when there's a particularly tragic death in an emergency room. There's been more recognition of those things. I think a lot of that came out of COVID. And because there were a number of physicians who very tragically killed themselves during COVID because they just got overwhelmed with everything that was going on. But I can remember I did a pediatric oncology rotation as a fourth-year medical student. So that was a long time ago. And we took care of a patient, and I can still remember her name. She was a young woman, and she would have been in high school, but she spent an entire year in the hospital. And the attending physician, we would sit down around a conference table and and talk about every patient on the service. And the attending physician had a 3x5 card. You had a stack of them, and each patient had a 3x5 card with their name on it. And he always had them in alphabetical order, and we'd go through the patients in alphabetical order. Some people did it by, like going around the rooms on the unit. And this young woman's last name started with a B. So she was often the first person who we talked about. And the morning after she died, we all sat down around the conference table, and he pulled his cards and he said, I still feel like we need to start talking about Miss B. And nobody said a word. We all just had a few minutes to be by ourselves with whatever our thoughts were. But he gave us that time. And then he said, and I think if anyone would have wanted to say something or felt like they needed help debriefing, I think he would have welcomed it. And then he went on, and we talked about the patient whose last name started with C or D, who was next in his stack of cards. But it made an impression on me that even then he recognized that this was a hard thing we had been through, taking care of this young woman who had, like I said, a 6 or 7 month hospitalization from the time she was diagnosed until she died. She never left the hospital. She had a really horrible sarcoma. And that it was hard for everyone. I think, in oncology, there's been some recognition of it over the years. I think the people who have always done it best is psychiatry. And I think other specialties have begun to learn from that it's important, because otherwise, we talk about burnout, but you get to the point where you just can't do it anymore. It becomes too hard. And if you want to be able to do this work for an entire career, you have to find a way to make sure that it doesn't become too hard.
I know that you also pioneered and started palliative programs at different New York City teaching hospitals. So I would like to hear a little bit more about that and what the process was and how you got involved in it.
It was another one of those putting myself out there and asking so that eventually somebody could say yes. You have to hear a lot of no's in the process, but I wanted to stay in New York after I finished my fellowship, and I wasn't able to secure grant funding to do research and stay at Sloan Kettering, where I had done my training. But I did want to stay in New York. I really was enjoying to my surprise, being in a big city, but mostly being in a very rich and enriching Orthodox Jewish community, which was not the case where I had been in the Midwest. And so I wrote to every medical school and major affiliate teaching hospital and said, I'm an oncologist who is interested in the care of the advanced cancer patient, and I've done this additional training in, pain and symptom management for cancer patients. And I'd love to talk to you about a job, because I'm ready to, finish my training and be an attending. And I interviewed at a number of places around the city. And the Department of Veterans Affairs was just starting to require that every VA in the country provide some level of palliative care services for veterans that they cared for. And I wound up getting a job in the VA. And they had this mandate they had to meet. I kind of fell in their lap in a way that was very good for me and good for them. And they had strong incentive to give me administrative support and backing to help develop a palliative care program within the VA in Brooklyn, which was where I had my first job. And that was affiliated with SUNY Downstate Medical School. So I had a faculty appointment there. And I really helped build a program from the ground up, taking care of patients who had serious illness, primarily cancer, because I did have this oncology background and was the person who was charged with meeting this mandate in the VA happened to be the chief of oncology. But we expanded to see patients with, bad COPD, advanced heart failure, renal failure who were not doing well on dialysis. So we saw people with all kinds of serious illnesses, mostly men, because that was the nature of the patients in the VA in the early 90s, and put together a team that included a social worker. And by the time I left, after being there for 5 years, we had a couple nurse practitioners. We had several physicians from other specialties, like a pulmonologist and a critical care doctor, who became very interested and were starting to learn some palliative care skills. And the specialty was really sort of coming to gel in the United States at that point. I finished my palliative care training at Memorial in 1995, and recognition as a specialty happened in 2008, if I'm not mistaken. So,
Wow.
Those first 5 years at the VA, things were starting to happen. And it was really incredibly gratifying to build that program and have a service available to these veterans who had, served their country and now were with serious illnesses at the ends of their lives, and make sure that they were able to live as best they could with those bad illnesses that were with them at the end of their lives, and that they were taken care of with dignity and with respect and with consideration for their families and what was important for them. And to do it with this interdisciplinary group of colleagues who we all worked together. And I went from there to another hospital, which had a small program already, and I served as the clinical director. So I was they had some funded researchers who were doing research in palliative care and palliative care adjacent fields, some medical ethics, some geriatrics, and some communication skills. And I was charged with building up the clinical side of things, which I did for a few years. And then I came to Maimonides, a teaching hospital, community hospital in the heart of Borough Park, Brooklyn, that I'm sure many of your listeners are familiar with. And I similarly had a charge with starting a palliative care program, initially within the oncology program. And that was a fundamentally different experience because I was told, oh, we tried to do palliative care here before, and it doesn't fly. It's not okay in the culture of our hospital. There are many of the patients that we serve and many of the staff are opposed to palliative care. And I thought, how could they be opposed to palliative care? Like, don't you want people with serious illness to feel as good as they can for as long as they can? Who could be opposed to that? It was like mom and apple pie. And then I heard that the opposition was on religious grounds, and that it was because it wasn't okay with Orthodox Jews. But I was an Orthodox Jew, and it was what I did. So it made the administrators kind of scratch their head. And we had a lot of conversations about what had been done wrong in this previous unsuccessful initiative and how we could do something that we thought would be successful. And I came and spent 15 years at Maimonides and helped build up from the first day seeing one patient as a consult to a service that saw several hundred new patients every year and had 3 full-time physicians. And I think when I left, we had 5 or 6 nurse practitioners, a couple social workers, and was really an integral part of the hospital in terms of helping to take care of patients. And, certainly during that time, patients who were in hospitals were increasingly sick because the bar for being able to get hospitalized was getting higher and higher because of a lot of factors related to the culture of medicine. And the bar to be discharged was also higher. We were discharging sicker patients. And so the sickest of the sick, even outside the ICU, were the patients who were in the hospital.
I'm going to actually ask you a question on how you deal with conflicts with people's perspective on halacha and end-of-life issues that come up, both, I guess, on the Orthodox Jewish side and on the medical professional side. How do you navigate those issues?
Those were things that I had encountered some issues with earlier on in my career, but really came to be something that I had to think about and process and make an understanding both with myself and figure out ways to navigate during my years at Maimonides. I think that much of it, the conflicts are perceived conflicts that result from misunderstandings or incomplete understandings. And many of them are kind of straw men. You will hear sort of half sentences like, we don't believe in quality of life. Oh, yes, we do. We think quality of life is a good thing. Nobody is in favor of suffering, unnecessary suffering. We recognize that sometimes there's suffering that comes in situations, but if it's avoidable, by all means. And I think what happens is that, we don't think that quality of life is an absolute value and that we should always sacrifice enormous amounts of time and potential longevity for small increases in quality of life. That's what people are trying, I think, to communicate when they say, we don't think quality of life, that's not a value that we hold. So it's really often about helping people think through, by approaching with curiosity, what they're really trying to communicate. And, we have, in the Orthodox Jewish community, there are often some very different attitudes that in general society about our elders in the community are, having the honor of taking care of aging parents or grandparents, wanting to have people, all the grandchildren taking turns sleeping over in the hospital if Bubby has to be in the hospital. and that's not a burden, that's a privilege. And that, okay, if my children have to help me, I might prefer to be able to be independent, but I'll let them help me. That's, that's the way it works. I helped my parents. My children will help me if I'm at a point where I need it. That's the way things are in life, rather than, a huge focus on independence. And if I can't do absolutely everything completely independently, then my life is of no use and no value to me. So I think, there are certainly places where those values differ. And one of the things that helps me in palliative medicine is that we are always looking to see what are the values of the patient and how can we tailor their care to what matters to them. So if I have a patient who's very willing to accept assistance from their family and, move in with the daughter, that really changes what the plan is compared to a patient who is not willing to accept any assistance. And if they can't go home to live in the community in their apartment by themselves, they're not interested. And so one of the things that's very satisfying about the field is that we really get to know the patients and help them understand what's important to them, and then work with all of the doctors and nurses and social workers and different, healthcare professionals who are in their care to come up with a plan that's really tailored to what matters to them.
It sounds like you really deal with the psychosocial aspect of the patient, not just the medicine and dealing with pain, but also dealing with the different factors that come up in each patient's life based off of the situations that they're in. I was wondering if you ever get approached by medical professionals that aren't Orthodox or aren't Jewish at all about asking you perspectives on halacha and end of life issues, and if there are any misconceptions on that side of the field.
Oh, absolutely. I mean, I think having grown up in the Midwest where there were not a lot of, it was a small Jewish community, I was somebody who was very accustomed to being asked questions about being Jewish by my friends growing up, and I very much, I'm always very grateful when people tell me they feel comfortable approaching me with those questions, because I think it's important for us to be able to have someone that we can approach with curiosity and respect about things that we don't know, especially when they're very personal, like someone's religion or culture. And I'm grateful that I have colleagues who come from, who are not Orthodox Jews, and I can ask them about their religion and culture when it's helpful for me, taking care of a patient or just being a good colleague for them. And so I get asked those questions a lot, often by people who are struggling to understand it. And being able to help a colleague understand why a family is making a choice for a patient who's not able to speak for themselves, that doesn't seem like it's the choice that colleague would have made for themselves or their parent, but helping them understand what are the values that lead this family to make the decision for their loved one, and why it makes sense for them, who they are and what they believe. It's really very satisfying to be able to help people do that, because it helps decrease the potential for moral distress that colleague or the nurses who are working with the patient or the physical therapist or the respiratory therapist are feeling around being asked to do things that it's hard for them on its face to understand why it makes sense and why it's a good. And I can't always give all the answers by any stretch of the imagination, but oftentimes I am able to be a little bit of a sort of cultural interpreter for people. One of the things I did that was probably among the most satisfying things during my years there was we did an educational project helping rabbis understand how they can be helpful in family meetings around critical decisions, often, but not always, CPR and intubation, mechanical ventilation, sometimes about transfer to an ICU, but really high stakes, very emotionally charged decisions where patients and families want to make sure that they're not making a decision that goes against halacha. And so they need to have a Rav Paskin, whether this is acceptable or not. And that means the Rav needs to understand the medical situation and what the options are, and how they would be expected to play out so that he can give that psak. And just like any other area, he has to have very clear information and a high level of understanding in order to be able to do that. And at the same time, we educated physicians who were not Orthodox, primarily not Jewish, but we had some who were Jewish and not observant themselves, do the complementary task of giving that information over to a rabbi when there's a question, so that we were able to help ensure that the rabbi had accurate, clear information rather than information that was passed to them second or third hand by a few relatives, the only one of which had actually gotten it from a physician and may not have understood it very clearly. And that not only did it change my practice to incorporate offering to do that whenever I was working with an Orthodox family that had to make these kinds of important decisions, but I saw how it changed the experience of taking care of seriously ill patients or my colleagues in every discipline, because it enabled them to see how there was consistency, and the process of coming to the decision was one that had a lot of validity to it. It wasn't that the patients asked the rabbi, should they have amoxicillin or erythromycin, and the rabbi was practicing medicine without a license. This was about taking a decision and seeing, did Jewish law permit it or not under these specific circumstances. And once they were able to see that this was a very valid process that came up with an answer that was really good and appropriate for this patient and this family, it was much easier to accept that, no, it's not what I would do for my mom or my sister, but I definitely see why this is the right thing for their mom or their sister. And I can feel good about being a part of doing what's the right thing for this patient and family.
That's a really nuanced idea, though, discussing how you could get rabbis involved and that they're not the doctor. So I find it really fascinating that you were able to bridge those two worlds.
Yeah, I kind of developed this little niche specialty about palliative care for Orthodox Jews, and I gave talks around the tri-state area.
Wow.
To lay people, to synagogue education programs, together with rebbeim and social workers. They were organized by the Orthodox Union. We got to do some work with RCA, with the National Council of Young Israel, with the different, with Yehuda, with really different groups across the spectrum of the Orthodox Jewish community around these issues of end-of-life care, and making sure that a person is prepared to get good care in the setting of a crisis or a serious illness. And I think that's one of the other myths, is that, we don't talk about serious illness and end of life, and we sort of don't admit that we die. And all you have to do is go to Shul and listen to the Parshas, and you hear, as soon as we get through the holidays, you start to hear about, Sarah dies and she's grieved for, and, our patriarchs prepared for their deaths. They, gave ethical wills, is what they're called in the modern day, but they gave over wisdom that they wanted their children to carry forward into the world. They prepared for their deaths. And so the notion that we don't, we're mortal because that's the way Hashem made the world. And so it's not that we don't accept mortality. It's a difficult thing that we're mortal, and it is sometimes be a very sad thing to deal with the death of someone that we love. But it's not, that's very much a myth that we're in denial about the fact that, all of us will one day die. And so I think being able to wade into that territory with a comfortable footing and not feel like it's a third rail is something that's, very helpful. and helping people learn ways to approach important topics in a way that will be sensitive and appropriate, but also give the patient and the family some control to say, we can talk about it for a little bit, but then it's going to get too hard and we're going to need to take a break. And then we can talk about it some more the next visit. I think that that's part of being just respectful to the patient and the family whenever you're doing anything that's really hard.
I guess one more question about palliative care, and then we could get more into, I know we've been talking a lot about being orthodox in the palliative care field. And you were saying when you started medicine, there weren't any women, there weren't a lot of women, let alone from women. So can you maybe tell us a little bit about some insights that you didn't anticipate in your specialty from women?
Palliative medicine, as it's evolved, actually has, I think, a disproportionate number of women in it. And people could probably speculate as to why that's the case. There are very few from people in palliative care, and I think that has a lot to, those of us who are in it, we sort of can take a head count, and I think there are maybe about 10 of us at this point. My youngest son went away for a gap year after he finished high school, and he called me before Shabbos, and he said, "Ima, do you know a palliative care oncology doctor named Dina Davidowitz?" And I said, "No, I don't think so. Should I know her?" And in the background, I hear a voice saying, "Ima, do you know a palliative care oncology doctor named Beth Popp?" And I said, what's going on? And he said, "I found out that my chavrusa's mom is a palliative care oncologist."
Wow.
And there can't be very many from women palliative care oncologists in the world. We figured you both had to know each other. So of course, and the voice in the background was his chavrusa talking to his mom. And of course, we were both by our computers and we quickly Googled one another. And we realized that the reason why we didn't know each other was because she's a pediatric palliative care doctor. She was just recently interviewed on one of the JOWMA podcasts. She did a beautiful podcast, and it's a great description of palliative care in pediatrics, which I don't do. And I do only adults. And so our paths had never crossed. But they have since then. And we've gotten to know each other and collaborate on a few things. So, there are so few palliative care doctors. And because of the cultural sensitivity and the worries that Orthodox Jews often have in the healthcare setting about their values being respected in a way that sometimes isn't, because they are different than some of the values that are primarily touted as the sort of mainstream American values right now. I'm not sure that that's true, because I meet lots of people who make the same decisions for their family members that I've seen Orthodox Jewish families make. And I've seen a wide variety of decisions that Orthodox Jewish patients and families make. But that said, the members of the Orthodox Jewish community are often approaching these healthcare situations with a lot of anxiety and worry about their values being respected, and how to successfully advocate for the care for their loved one that they understand to be consistent with halacha, because they want every moment of this person's life to be consistent with halacha, and it has been up until now, and they don't want it to change at the very ends of their life. And so I think there's a real opportunity for Orthodox physicians to make an important difference in our community, to ensure that our patients, our community, our families can get good quality care and be less anxious about one more thing in a critical time, because they can know that there is someone like them. In a lot of medical education these days, you hear a lot about representation. And if you have somebody who's like you, or that somebody in the department is like you, that they may have had an influence, and you can be more comfortable that you'll get care that's appropriate for you and who you are and what you value.
That's so beautiful that you're able to help people through those times, especially because there aren't so many Orthodox palliative care professionals, that you're able to balance those two values. And I'm sure after listening to this podcast, I'm hoping there will be more people that are interested in going into it, because it sounds like it's a real need to have people going into this specialty. How did you get involved in JOWMA?
I read about JOWMA in one of the weekly newspapers that I peruse over Shabbos and got very excited. This was a few years ago, about the idea that there was an opportunity to get together and learn from and network with other Orthodox Jewish women, because while there were a few Orthodox women physicians during my years, that were colleagues during my years at Maimonides, in all my other jobs, maybe there was one other person in the hospital who was Orthodox Jewish physician. I might have colleagues in other fields, nursing or physical therapy, but not physicians. And so that really struck me as something that was a great opportunity that I would want to be a part of. And when I didn't get so involved in the earliest days, because it was sort of centered, I think, more in the Five Towns where some of the founders were based. And then during the first part of the pandemic, and just prior to that, when JOWMA was really involved in a lot of public health education around measles outbreak and around COVID, I was really excited about that same notion of, I have an opportunity to help make sure that my community gets through this in the best possible way. Yes, I'm taking care of everybody from every community as my day job, and I'm doing that with great pleasure. And I love the diversity of the patient population that I take care of. And I don't want my community, my neighbors, my friends, and their parents and their children to be left out of that, getting great care. And this is an opportunity. And so that got me even more interested. And then when I found out about the mentoring aspect and helping, young women physicians apply for residencies or think about challenging issues when they were negotiating for their first jobs, or what kind of a job did they want to stay in academic medicine or go out into private practice, or applying to medical school or applying for residency. I just saw it as a really wonderful opportunity to give back and to help make sure that there were more women in medicine and that they were going into medicine with their eyes open. There are things that are challenging and difficult, and that's okay. There are things that are challenging and difficult in every career that anyone would choose. And there are things that are challenging and difficult when you're not from. But I think what's most important is to have someone as a mentor that can help you go in with your eyes open, understand what the challenges will be, have a plan to address some of those challenges or to get through some of those challenges, because you can't always mitigate them. Sometimes the only way to the other side is just to go through it. That was really an exciting opportunity for me. I have tremendous admiration for some of the physicians that I see coming through the ranks. I didn't get married until after I finished this palliative care fellowship I had done. So I didn't have children while I was in training. And when I see now, colleagues to be early in their training who are getting support and assistance to navigate starting their family while they're in medical school or residency and figuring out childcare arrangements for residency, I really have a lot of admiration for the fact that one can do those things, and that there are people to give guidance, and that everyone doesn't have to be their own trailblazer.
And just more talking about mentoring, if I could just ask you one last question. If you could give advice to any medical or pre-medical students, what would that be advice be?
It's definitely important to find mentors You don't have to have just one. You can have different mentors for different aspects of your professional growth, and really cultivate those relationships and build them because they're invaluable. And don't be afraid to ask, because nobody can say yes if you don't ask.
Thank you so much, Dr. Popp, for coming on. It was so fascinating to hear about your field. And there's definitely a lot more questions I'd love to ask at a different time. But we really, really appreciate learning all about your field. And thank you.
It's my pleasure. If there are residents or med students out there who are interested to learn more, get in touch through JOWMA, and we'll see if we can help you find opportunities to learn more.
Thank you for listening to the JOWMA podcast. We welcome your feedback and ideas for future episodes. Send us an email at health@jowma.org. Don't forget to subscribe, rate, and review us on your favorite podcast platform.